Good morning, I'm Colin. I work with the Drugs for Neglected Diseases Initiative's Chagas Access Program. And I'm going to talk this morning about the relationship between R&D and the needs of patients with Chagas disease. So first, let's put the issue into historical perspective. Chagas disease has existed in what is now the United States for centuries. And the first case that we know about was found in human remains that are over 1,000 years old from the Pecos Valley of Texas that exhibited evidence of T. cruzi infection as well as Chagasic megacolon. The first clinically confirmed case of autochthonous transmission in the modern era was in Texas in 1955. Our only two effective medications were developed over 40 years ago, but are still not approved by the FDA. We've only recently began monitoring of the blood supply. And according to the most recent estimates, there are over 300,000 people living with Chagas disease in the United States today. I know Dr. Hotez earlier gave the figure of 238,000, and that's based on legal immigration, but if we factor in undocumented as well, that number goes well over 300,000, and it's likely an underestimate because it's not including autochthonous cases. And less than 1% have received diagnosis. And in the United States, less than 0.2% have received antitrypanosomal treatment. So the Drugs for Neglected Diseases Initiative is a nonprofit organization that grew out of Doctors Without Borders in 1999. And DNDi's mission is to provide medications for conditions that are either neglected or underserved by the prevailing pharmaceutical model of R&D, which is market and profit-based. Chagas disease is one of our priorities, given that no effective new medication has been developed in over 40 years. And in conjunction with researchers, partners, and other stakeholders, we established a framework for an ideal treatment. Such a drug would be effective in all phases of the disease and against all T. cruzi strains. It would be at least as efficacious as Benznidazole, the current first-line therapy, but it would have a superior safety profile. And to facilitate its use by patients, it would be ideally oral once a day, and the regimen would be completed in 30 days or less. So in the short term, we're working on optimizing the current therapies, Benznidazole and nifurtimox, by determining ideal dosages and treatment periods. We're also working on the development of new compounds, and this includes looking at combinations with Benznidazole. And also we maintain a web-based virtual network of researchers, the Chagas Clinical Research Platform, and we hold an annual meeting for that platform. If anybody would like more information about joining that, please feel free to talk to me later. So right now, one of the main issues with both Benznidazole and nifurtimox is the high level of side effects. These cause about 20% of patients to drop out of treatment, and they increase in severity and frequency with patient age. And because of the possibility of side effects, patients require additional monitoring and find it more difficult to go about their daily lives. And I provided a couple of quotes here from patients who were unable to tolerate either medication. For time, I'm just going to read the first. One went to my head. It was like it erased my mind, and I think I lasted 1 or 2 weeks taking it. And then they gave me another, and my hands started to swell, and I got spots and a rash and all that. I also took that one 2 or 3 weeks, and then I told the doctor that I wasn't going to be able to take it anymore. So an important research question for patients is, are drug dosages too high, or is the exposure period too long, and is this what's contributing to the high level of side effects? So to answer that question, we have a new study ongoing. It's a phase 2 proof of concept study called BENDITA. And there are sort of 2 antecedents to this study. The first is that evidence has come out showing that smaller doses of Benznidazole or shorter treatment periods might be just as efficacious as what we're currently using. The second is a couple years ago we had run a phase 2 study of E1224, which showed that this compound was very good at initial parasite clearance, but unfortunately that effect was not well sustained at 12 months follow-up. Still, it raised the possibility that possibly a combination of E1224 and benznidazole at lower doses could be effective while producing fewer side effects. So BENDITA is a 9-arm, 3-country study, and I apologize for the quality of the slide, but each arm has different combinations of dosages or treatment lengths for benznidazole, and in 3 of the arms there's also a combination with 8 weeks of E1224. The study is already underway in Bolivia, and completion is optimistically projected for the end of 2018. So developing a better medication will certainly be helpful, but even if we have an ideal treatment tomorrow, will we be able to deliver it to the patients who need it, keeping in mind that currently less than 0.2% of U.S. patients are receiving antitrypanosomal therapy? So obviously there are a whole host of barriers that are impeding patients' access to receiving medical care for Chagas disease in the United States. And I find it helpful to group them into 4 overlapping and interconnected dimensions, as I've pictured here. Another important point to keep in mind is that while we're focusing primarily on the clinical aspects of the disease, patients are experiencing it in social and emotional realms as well. So in this diagram, I've put the 4 barriers that I showed in the previous picture and listed examples of each. Our focus in this panel is primarily on the clinical barriers, which includes the toxicity of the medications, but it's important to mention that this realm is closely interrelated with the other 3. Systemic barriers are deficiencies in the public health system that cripple our ability to provide adequate care to the patient population with Chagas disease. This includes the lack of approval for the medications, as well as the almost complete absence of routine screening for Chagas disease in primary care. Structural barriers refer to political and economic divisions and inequalities in society that impede access to treatment especially for certain marginalized groups, such as immigrants. And psychosocial barriers are cultural beliefs, internal perceptions and fears within patients, and societal attitudes. An example of this would be the stigmatization of Chagas as a disease only of the poor or of immigrants. So to begin to address these barriers, DNDi has launched a Chagas Access Project with operations in Mexico, Colombia, Brazil, the Gran Chaco region of South America, and here in the United States. And this new focus on access stems from 2 precedents that are fairly recent. The first is a paradigm shift in how we treat Chagas disease and the realization that adults in the indeterminate chronic phase of the disease should receive antitrypanosomal therapy. And the second is a shift in emphasis in public health circles from vector control to patient care. We're also collaborating with the Colombian Ministry of Health to implement a pilot project in 4 endemic municipalities. And this includes a patient-centered roadmap that will improve access to medical services in those areas. And we hope that this can serve as a model for other programs throughout the Americas. In the U.S., our goals are to support the many people who are already working to expand treatment for Chagas disease. We also want to stimulate the production of clinical, epidemiological, and other types of evidence that can guide programs. And finally, identify the barriers that are preventing so many people from receiving treatment right now. So again, just to give an example of structural barriers, for one high-risk group for Chagas disease, Latin American immigrants, we can see median annual income is only 2/3 of that for non-Latino whites. And if you look at immigration status, there's sort of a dose-response relationship. The worse your immigration status, the harder it is to have insurance coverage. Now, granted, this is pre-Affordable Care Act, but even after that act was implemented, Latinos still represented the group with the highest levels of non-coverage. And of course, we could be going back to this system soon. So just who are the people with Chagas disease in the United States? At the Center of Excellence for Chagas Disease in Los Angeles, we conducted a preliminary study interviewing 50 patients with Chagas disease. And we noted that this is a group with a high level of vulnerability. As you can see here, 60% lacked a high school education. Nearly 3/4 are dependent on Medicaid. And we're not talking about immigrants who've recently come across the border. On average, they had lived in the United States for over 20 years. Most lived in households that were below the federal poverty line. And I think these quotes here illustrate the precariousness of their health care. This person who just got a job as a cashier, I've changed their names obviously. Lately I've had problems because they want to take away my Medi-Cal because I started working, and I'm afraid because with this Chagas, I don't know. And this gentleman says, I don't have Obamacare, and the government enacted a law that people who worked could no longer get treatment. A law that I no longer qualified, so I stopped going to my appointments. We asked patients what the most difficult part of adjusting to life in the United States was, and understandably the most said language. In terms of what would facilitate going to the doctor, the most common reasons given were transportation, more insurance coverage, and financial support. So again, there are a whole host of challenges that we're going to have to face if we want to begin to reach the population of people that's not getting treatment for Chagas disease right now. And again, I want to emphasize that while we're focusing on sort of the clinical implications of the disease, patients are experiencing it in their social lives and emotionally as well. Just the mere diagnosis of Chagas disease can create considerable anguish, as these quotes here illustrate, I think. I felt terrible that the sky was falling, that I was going to leave my daughter behind, that I was going to die without seeing my grandkids. I felt like crying. I was devastated. I'm always in panic that these larvae will grow in my blood. It's always in my thoughts. I don't want to die. I want to live. My brother died from Chagas, and I don't want to die. I'm only 57. I want to see my family and my grandkids grow. Once I learned more about Chagas disease, I started to worry. I became depressed. I felt very sad because you don't know if you're going to die tomorrow or what. I felt down, sad, without desire to do anything, and insomnia. So just the fact that you're diagnosed with Chagas disease, regardless of the level of symptoms you're experiencing, means that you have to live the rest of your life with the gnawing worry that death could come at any time, as we know that it can. And not surprisingly, one study found that over 40% of people with Chagas disease experience depressive symptoms. So an important question is, what kind of resources are we giving patients diagnosed with Chagas disease to deal with the emotional and social impacts? What do patients feel are the most important action items for eliminating the problem of Chagas disease? The most common reasons, or the most common suggestions given were to provide more information, to develop better medicines, to increase screening, and to make treatment inaccessible. And I don't think that's incompatible with what the rest of us here are thinking. So finally, in this slide, I've again revisited the 4 dimensions of barriers that I mentioned earlier, and I've proposed steps that we can take to mitigate each. So while it's important that we develop safer, more effective drugs and a more reliable test of cure, at the same time there are a variety of other actions we should be taking. And this should be done in a simultaneous fashion if we're ever to start reaching the 99% of people who are currently untreated. Thank you.